Alright, we're going to cover coagulation disorders. This is by Lauren Wilcox, Chelsea Soring, Stephanie Haldeman, and Danny Marini. Okay, we're going to talk about platelets and coagulation cascade before we continue on to cover coagulation disorders. So platelets are your main filling source when there is injury to the vasculature. In other words, they go in and kind of clog up that area. And they are made from megakaryocytes, which are made from megablastocytes that come from the bone marrow. They last up to 7 to 10 days, after which they are then sent to the spleen where they are phagocytized. Okay, now I'm going to talk about the function of platelets. Anytime there's endothelial damage and vascular, you're going to get bleeding out. And so we need platelets to attach to this area and pretty much clog up the hole, or clog up the area where the bleeding is occurring. To help platelets stick to the damaged area as well as to each other, there are certain factors that platelets have attached to them, and they're called glycoproteins. These glycoproteins allow for adhesion to the injured site, as well as they allow for adhesion of platelet to platelet. And so we need these factors as well as platelets in order to prevent people from bleeding out, or from ourselves from bleeding out from injury. There are certain disease processes as well as drugs that can interfere with either the formation of platelets in themselves or with these factors like glycoproteins to prevent platelets from forming. And this is a problem because if we can't form a platelet plug, then the patient or ourselves will end up bleeding out. So now we're going to talk about the 3 steps of coagulation. This occurs when there is vascular injury. And so endothelium injury, you can see there's a cut in the slide right here. What happens is that the smooth muscle around the blood vessels will actually contract and constrict to help close off that injured area. Alright, in the second stage of in coagulation, it's called the platelet plug formation. And so what happens is you get von Willebrand factors that lay down of the exposed site. And this von Willebrand factor allows for platelets to attach to that site. And once these platelets attach, they themselves will release ADP as well as thromboxane A2, which will attract more platelets to bind to that area. Eventually we'll get calcium that comes in and helps bind, and this is the formation of that plug over the injury site. Okay, so the second step we talked about was the formation of the platelet plug. Now we're going to talk about the coagulation cascade. The platelet plug ends up being stabilized by a fibrous protein called fibrin. This fibrin is activated through either the extrinsic or intrinsic pathways. As you look here on the right on the PowerPoint slide, you can see that there's several steps that take place in order for this fibrin mesh to be made to help stabilize the platelet plug that is now forming. Okay, now the formation of this platelet plug as well as the coagulation cascade is very important, like I've said a number of times, to keep us from bleeding. However, if we are clotting too much, that can also lead to a disease process as well. And so we have to have checks and balances. You don't want to be bleeding out too much. At the same time, you don't want to be clotting too much as well. And so our body has several checks and balances, such as protein C and S, as well as antithrombin 3, which these help regulate how much clotting can occur. If you're deficient in any of these proteins there, you're going to be in a hypercoagulability state, meaning that you're going to clot more than you should, and these clots can occlude certain blood vessels that are important for tissue and organs and lead to ischemia in those areas. Also remember that it is the release of thrombin that converts fibrinogen into fibrin, and fibrin, once again, is the mesh that really stabilizes the platelet plug. Alright, so now that we know about the coagulation factors and what takes place to form a clot, we're going to start talking about some of the disease processes that come from our body being unable to form the clot that we need to prevent bleeding. And so we know that when we get hurt, our body instantly will begin the coagulation process to prevent the bleeding from occurring. Now, one of the issues that it can occur is what we call thrombocytopenia, which meaning you have low platelet count. And so if you're low in platelets, remember I talked about the platelets are largely the material that we use to clog up a hole. If we're low in platelets, that means we're not clogging up that hole or that injury to prevent bleeding. And so always think of that. When you hear thrombocytopenia, think of bleeding. With primary hemostatic disorders, the issue of not forming a clot is due to inhibition forming a platelet plug. This is manifested by a patient coming in and generally having bleeding in the gums or in the nose. So if the disorder affects the coagulation cascade, you will see hemiarthrosis or hematoma. Hemiarthrosis is bleeding into a joint, and hematoma is bleeding, it's a collection of blood outside the blood vessels. When it affects the coagulation cascade, it is known as a secondary hemostatic disorder. Alright, so with the coagulation disorders, remember that there is a primary and secondary. Now we're going to talk about the different types of thrombocytopenia. Remember that thrombocytopenia means you are low in platelets. So we have idiopathic thrombocytopenia pura pura, thrombotic thrombocytopenia pura pura, hemolytic uremic syndrome, disseminated intravascular coagulation, and drug-induced. And drug-induced means that mainly it's caused by heparin. It causes you to bleed out, and I'll explain more of that here in the next slide. Okay, we're going to cover idiopathic thrombocytopenic pura pura. It can also be called autoimmune thrombocytopenic pura pura. The reason why it's called autoimmune is if you go down the slide, you can see that children, after 1 to 3 weeks of having a viral infection, will make antibodies to fight off this viral infection, or even a bacterial infection, but more commonly with viral infections. So what happens is these antibodies that have fought off the viral infection will now recognize your platelets or their platelets as being a foreign body. So the body will actually attack these platelets and destroy them. So when you do blood tests, it's going to show having a low platelet count because these platelets are being destroyed. This disease is manifested by mucosal bleeding, petechia, as well as pura pura. And it's often very self-limiting. In other words, it gets better on its own. Right, thrombotic thrombocytopenic pura pura. What you're going to see here is microangiopathic hemolytic anemia. Microangiopathic means that there is pathology going on inside the smallest of blood vessels, like atrials and capillaries. And so for whatever reason, these capillaries are injured and they're forming that fibrin mesh that leads to clotting. However, this fibrin mesh can act like a bunch of, think of like jagged glass sticking up. And as red blood cells are going through around this jagged glass and they hit it, it's going to cut them open. And that's where you get the hemolytic in the name. So these red blood cells are getting cut open, and pieces of them are floating away, and these pieces can look like helmets under a peripheral smear, and it's called cystocytes. With this, you can also see thrombocytopenia, which is low platelets, CNS abnormalities, fever, as well as renal failure. Okay, hemolytic uremic syndrome. Okay, I'm going to try to explain the pathology here, or why these symptoms you see on the bottom occur. So you get a triad, which is fulminant thrombocytopenia, hemolytic anemia, and renal failure. So what happens here is there is damage being caused to the endothelium and the glomerulus, and this damage leads to the clotting cascade. Now, the damage that occurs there is caused by generally like toxins from E. coli or Shigella or Salmonella. And so the damage comes in, you get these clotting factors that occur, and these clotting factors start clogging up the small atrials around the glomeruli. This is a problem because it leads to ischemia in that part of the kidney, and that's where you start to see renal failure. As well as you start getting that fibrin mesh that forms, and remember that I said that fibrin mesh kind of represents glass, and it can cut up red blood cells, and so you'll start getting those lysed red blood cells going through it. That's where you get the hemolytic anemia. And then because there is damage in the endothelium, and you're having clotting factors, you're going to release platelets, and so you're going to be low on platelets because you're using a lot of platelets to repair the damage done in the kidneys. And so that's where you're going to get thrombocytopenia. Alright, disseminated intravascular coagulation. I really find this disease process to be interesting, right? Because I was kind of confused about it for a long time. Because you go from a hypercoagulability state to a hypocoagulability state. So you go from where you just, I know this is the technical jargon, but you're clotting like crazy to now you're just bleeding out. And so how does this occur? Well, the causes can be due to malignancy, a massive trauma, sepsis, or leukemia. But what happens is that one of these causes can lead to damage of the blood vessels, but the damage can be so severe that the body is reacting instantly. And so you are activating your coagulation cascade, and as you're doing this, all the material needed to form a clot is getting used up really fast. And so you're building these clots that can float around in the body and actually can lead to damage by clogging up certain areas or clogging up certain arteries or organs. But as well as you burn up all this material, so now you've got no material left and nothing to prevent you from stop bleeding, that you end up just continuing to bleed. So hopefully that makes sense. And so you have a bleeding, you have damage that's leading to bleeding, right? Your body overreacts, builds a ton of clotting factors, right? So you get this hypercoagulative state. You burn up all that material, so you no longer can form clots anymore to prevent bleed, and so now you just bleed out. And that's where disseminated intravascular coagulation comes from, and that's why it can be so severe, as well as that the patient can bleed out, or these thrombosis can actually occlude areas and cause end organ damage. Alright, we're talking about drug-induced thrombocytopenia, and the way you can differentiate between drug-induced thrombocytopenia and TTP is by the patient's history. If they are on drugs like heparin, and there's other drugs that can lead to this, you should think of DIT. The reason being is that heparin can cause antibodies to be formed towards the heparin platelet factor 4 complexes, which eventually will break down platelets, leading to thrombocytopenia, and you can also get a hypercoagulability state from this as well. So the main treatment, of course, to fix this is to take the patient off this drug, and then the symptoms will go away.